Good afternoon, everyone. Of course, ladies and gentlemen, guests and colleagues, magandang hapon po sa inyong lahat. And on behalf of the Makati Medical Center Heart Institute and the section of cardiology, it is my pleasure to welcome you all to today's Heart Forum entitled The New Era of Heart Failure Therapy, from Neurohormonal Blockade to Quadruple Therapy. I'm sure you're quite aware that heart failure remains one of the most significant challenges in cardiovascular medicine and international guidelines. We are honored, Professor, by your presence and grateful that you have joined us this afternoon. Well, we are delighted to welcome our participants here at the Math Medical Center, today's Heart Forum. I would like to acknowledge our colleagues who are joining us virtually. This forum is likewise being broadcast by a virtual platform to numerous cardiology training institutions and chapters of the Philippine Heart Association across the country. Moreover, as confirmed by our partner Camber Hetero Philippines, this educational activity is also being viewed by healthcare professionals and cardiology colleagues from several neighboring countries, including Indonesia, Myanmar, Malaysia, Thailand, Cambodia, Vietnam, Sri Lanka, and Nepal. To all of you, good morning to some and good afternoon to the rest of our colleagues out there. And to all our participants joining us online, whether here in the Philippines or elsewhere in Asia, again, thank you very much for being part of this important scientific meeting. We are honored by your presence and participation, and we warmly welcome you all to today's Heart Forum. I am Dr. Raul Lapitan. I'll be your Master of Ceremonies for this afternoon, and I'll be your moderator during this scientific session. But before we begin, allow me to request everyone to kindly silence your cell phone to virtual mode, turn them as a courtesy to our speaker and to our fellow participants. So to formally open our program, may I request everyone to rise for the invocation, and this will be followed by the national anthem and Makati Medical Center hymn.
Heavenly Father, we gather today with hearts full of anticipation and curiosity as we convene for this forum. We seek your wisdom and guidance as we explore the wonders of your creation through the lens of science and discovery. Bless every participant, speaker, and organizer with insight, clarity, and inspiration. Grant us the ability to think critically, communicate effectively, and collaborate harmoniously. May our discussions be fruitful, leading to new understandings and breakthroughs that benefit all of humanity. As we delve deeper into knowledge, may we always remember the greater purpose behind our pursuits. Let our work be a testament to your glory and a contribution to the betterment of our world. In your holy name, we pray. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, ewas ang sinakalan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, kuya ka ng magiting, sa mandulupin, di ka pasisigil, sa dagatang tutok sa simoy at sa langit kong bagaw, ay hinatang tulang awit sa paglayang minamahal. Ang isang ng katawan ko'y tagumpay na nag-iingin, ang bituin at karon niya kailan pang ay di magtitingin. Lupa ng araw ng buwan, hangin pagsingka, buhay langit sa piling mo. Ang hindi kaya na pagkay mga api, ang mamatay ng dahil sa'yo. Sunrise brings a new day, the city wakes once more. We bow our heads to God and pray His goodness we implore. We thank God for His blessings. We ask Him for the strength to face the task He gives to us to help our fellow men. We ease our neighbor's pain. We bring forth fresh new life. We mend the broken minds and bodies. For their health we strive. Compassion is our guide, and healing is our art. Makati Medical Center, the hospital with a heart. Makati Medical Center, the hospital with a heart.
Thank you. Please be seated. To deliver the welcome remarks, it is my privilege to introduce our Medical Director and Interim Co-President and CEO of the Makati Medical Center, also a past President of the Philippine Heart Association and past Governor of the American College of Cardiology Philippine Chapter. He's no longer doctor, he's Dr. Saturnino P. Javier.
Thank you very much, Raul. A very pleasant afternoon to each and everyone, including our virtual participants. I'm extremely privileged and honored to join you this afternoon. This is the initial activity of the Makati Medical Center Heart Institute, headed by Dr. Raul Lapitan. And there's no better way to start off our scientific foray by having a topic on congestive heart failure. As has been pointed out, we recognize the burden and the challenge of congestive heart failure, and certainly this afternoon will be a welcome opportunity to deepen our understanding of heart failure and its management and align our principles of management with evidence-based strategies. I'm heartened to note that we have a good turnout on a post-Independence Day Saturday afternoon activity, Raul. And certainly this puts you, Professor McMurray, as the core stimulus for people to gather this afternoon. I have no doubt that this afternoon symposium will be a source of learning for each and every one of us. On a personal note, thank you to all our dignitaries and luminaries from the cardiology community who have joined us this afternoon. Magandang hapon po sa inyo lahat. Thank you.
Thank you very much, Dr. Javier. And to formally open today's scientific forum, may I call on the Chief of Section of the Cardiology, Dr. Joel De La Rosa.
Professor John McMurray, our distinguished speaker for today, Dr. Bong Javier, our Medical Director, President CEO, Dr. Lapitan, Director of Makati Med Heart Institute, guests and colleagues, former and current President of the Philippine Heart Association, guests and colleagues here in Makati Medical Center, and to our esteemed virtual audience, tuning in from across the Philippines and across Asia. A pleasant good afternoon to all of you. We gather here today because we face a shared and formidable adversary. Across Asia, heart failure looks drastically different than it does in the West. We navigate incredibly diverse healthcare landscapes where the ultimate clinical challenge is transforming from global guideline-directed medical therapy to real-world localized patient access. As cardiovascular specialists, we share the unique burden from high rehospitalization rates and to the immense socioeconomic impact of out-of-pocket medical expense of our patients. Our challenge has always been translation. How do we take the landmark international guidelines and make them actionable, affordable, and accessible? Our keynote speaker for today has been in the forefront of defining how the world treats heart failure. We are privileged to be joined today by a world-renowned pioneer in heart failure whose clinical trials and research have fundamentally reshaped how this condition is diagnosed and treated globally. So we officially open today's Heart Forum about the new era of heart failure treatment. Let us take this opportunity to take the science we discuss here and translate it into longer, vibrant lines for our patient. I would like to take this opportunity to extend our deepest gratitude to the organizing committee headed by Dr. Lapitan and our cardiology fellows for their hard work. I would also like to thank our partners, Philippine Heart Association, Camber, Hetero, for all their support. Thank you for joining us this afternoon as we work towards the betterment of our heart failure patients. Thank you.
Thank you, Dr. De La Rosa. But before introducing to you our esteemed guest, the most distinguished speaker for this afternoon, allow me to call somebody. She's a respected leader in Philippine cardiology and has recently assumed the helm of the Philippine Heart Association. Her commitment to advancing cardiovascular care, professional development, and patient advocacy continues to inspire the cardiology community nationwide. To deliver a special message on behalf of the Philippine Heart Association, it is my distinct honor and privilege to introduce the President of the Philippine Heart Association, Dr. Aurora Muriel S. Gamponia.
Good afternoon, everyone. I'm still the Vice President as of this time. And Dr. Saturnino Javier, Medical Director, Interim Co-President and CEO, Dr. Joel De La Rosa, Chief Section of Cardiology, Dr. Noel Rosas, Director, Professional Services of the Makati Medical Center, distinguished members of the cardiology staff of the Makati Medical Center, and I've seen past presidents of the Philippine Heart Association, our honored guest, Dr. McMurray, colleagues and trainees, good afternoon. It's truly a privilege to represent the Philippine Heart Association and its officers at this important scientific forum. And we are profoundly honored to have a renowned pioneer in cardiovascular medicine, best known for his work on heart failure, and the opportunity to learn from Professor John McMurray is truly valuable. So, as we all know, heart failure remains one of the greatest challenges here in the Philippines, not only because of its mortality, but its impact on the patient's quality of life, healthcare system, and families. So currently, we have, it affects 10.4% of Filipino populations. So the Philippine Heart Association, through the Council of Heart Failure and the National Heart Failure Network, has become the forefront of advancing awareness, educating healthcare professionals, initiating the establishment of heart failure clinic across the country. Presently, most of our heart failure specialists are in Dumaguete, and this is about 10 of them, spreading the educational forum across the country. So there's also multi-sectoral collaborations with institutions like the Makati Medical Center, government institutions, also pharmaceuticals that would bring us to achieve our goals. And so we are therefore honored to have you, Dr. McMurray, and we look forward to major insights and new learnings, and this would be really a valuable help to every one of us here, especially the heart failure team. And so we would like also to express our sincere appreciation to the leadership of the Makati Medical Center Cardiology Institute and its organizing committee for bringing together cardiologists and clinicians to learn from Dr. McMurray. Makati Medical Center continues to demonstrate its unwavering commitment to advancing medical education and fostering excellence in cardiovascular care. So congratulations and thank you.
Thank you very much, Dr. Agamponia. As she has mentioned, she's still the current vice president of the association, but starting July 1, she'll start her duty steering the 1,800-member Philippine Heart Association, therefore. So allow me first to recognize the past presidents of the Philippine Heart Association, Dr. Bimbo Sibulo, Dr. Butch Recto, and of course, Dr. Baby Leos for coming over. And allow me to recognize the past medical director of the Makati Medical Center and the former section chief of cardiology, Dr. Benjamin Alimo. Thank you, sir. So, and now, for the meet of this afternoon, I am to introduce our Makati Medical Center Heart Institute distinguished speaker for this year's Heart Forum. It's my pleasure to call on the Director of Professional Services, Dr. Noel Rosas. Thank you, Doctor.
Thank you very much, Dr. Lapitan, and good afternoon to everyone. It is my great pleasure to introduce to you Professor John Joseph Valentine McMurray, one of the world leading authorities in cardiovascular medicine and heart failure research. Dr. McMurray is Professor of Medical Cardiology at the University of Glasgow and Honorary Consultant Cardiologist at the Queen Elizabeth University Hospital in Glasgow. Over a distinguished career spanning more than 3 decades, he has led and contributed to many of the landmark international clinical trials that have transformed the treatment of heart failure, cardiovascular diseases, diabetes, and chronic kidney disease. If you are a regular attendee of the European Society of Cardiology annual meeting, he is always a regular fixture in the late-breaking science and hotline session of the convention. So looking forward to see again Dr. McMurray this coming August in the hotline session. This is because he has authored more than 1,000 scientific publications. Many of them are landmark trials. Some of them he's going to discuss this afternoon. Reviews, editorial, books, and book chapter or letters. He also received over 500,000 citations and is an authority figure in the creation of guidelines in cardiovascular diseases, particularly in heart failure. Because of this, he is being recognized as a highly cited researcher. His many honors include the European Society of Cardiology Gold Medal, the Louis and Arthur Lucian Award, the Mackenzie Medal, and an OBE from Her Majesty Queen Elizabeth II for services to cardiovascular research. Guests, please join me in welcoming Professor John McMurray.
Good afternoon, ladies and gentlemen. Thank you very much for that great welcome. In fact, I've been absolutely overwhelmed since I arrived this morning by the welcome I've received. Thank you very much for coming along on a Saturday afternoon, especially since I hear it's a holiday weekend. So I'm very, very grateful that you've let me come and speak to you today about heart failure. And what I'm going to do is I'm going to take you on a historical journey. So for some of you, this will be revision. For some of you, this may be new. but I will try and show you some things that maybe, even though they're old, you might never have seen before. So today I'm going to talk about one type of heart failure in my presentation, which is heart failure with reduced ejection fraction, but I'll be very happy to talk to anybody afterwards about heart failure with preserved ejection fraction if you would like to do that. Now, I was asked to talk about a title that mentioned quadruple therapy, but as I'm going to explain to you, I don't think quadruple therapy is the right word or right words. I think it should be quintuple therapy, and maybe the most important message I would like you to take away today is that there are 5 life-saving treatments for patients with heart failure and reduced ejection fraction, not 4, and I'll explain that in more detail in the next few minutes. So these are my disclosures, and of course what we're talking about today, I'm sorry the video's not working, what we're talking about today are people with heart failure and reduced ejection fraction. So I want to talk about the so-called 4 pillars of treatment for these patients with an ejection fraction of 40% or less. And we're talking about the new era today, but I want to go through the different eras of heart failure therapeutics because I think it's interesting to go through this historical journey. So the original era, I would say, at least in the English language, started with digitalis glycosides, and I'll come back to those because even though they were first described as a treatment for heart failure in English 241 years ago, I'll show you that there's new evidence that these drugs are still relevant today. Then, of course, one of the big breakthroughs in the treatment of heart failure was the development of safe diuretic treatment, and that remains a core treatment for heart failure today, although the need for diuretic therapy is clearly less than it used to be. And then the start of the modern era was, of course, the introduction of neurohumeral blockade. And for me, as a young cardiologist training, this was a remarkable story because, of course, this explained something that we had been unable to explain before. Why do patients with heart failure get progressively worse? Or maybe I should say today, in 2026, why did patients with heart failure get progressively worse? Why did their symptoms deteriorate? Why did they get admitted to hospital more and more frequently? And then ultimately, why did they die prematurely? They weren't having another heart attack or their hypertension wasn't the problem. Something was causing this relentless progression, this vicious cycle of decline. And of course, our understanding became that what was doing this was neurohumeral activation, adverse neurohumeral or neurohormonal activation, activation of things like the renin-angiotensin system and sympathetic nervous system. And of course, the whole point of neurohumeral blockade, this newly introduced concept back in the late 1980s, was that if you could block these harmful, these detrimental neurohumeral pathways, you could break into this vicious cycle and you could reduce the rate of progression and decline in patients with heart failure. And of course, the first treatment to show this benefit were the ACE inhibitors. And in fact, when we say ACE inhibitors, the truth is it was one ACE inhibitor. The trials that showed evidence of benefit of ACE inhibitors both used enalapril, first the Consensus 1 trial and subsequently the SOLVE treatment trial. So here's a figure you've never seen before, and I don't think anybody had ever seen this figure before last week because this was never published and it was a slightly unusual finding. And as you can see here in this subgroup analysis of the SOLVE treatment trial, that was the trial with enalapril in symptomatic patients, and then I put the two SOLVE trials together just to see whether this was a real phenomenon or not. What you see here is that in the SOLVE trials, enalapril wasn't quite as effective in women as in men. This was never published. There's no subgroup analysis from the SOLVE trial published. When I saw this, I thought, this can't be right. This must be a mistake. So let's put the two SOLVE trials together, bigger numbers, more events, more robust data. Hopefully this will go away, but in fact this interaction strengthened. There's a very strong, statistically significant interaction whereby sex seems to modify the effect of ACE inhibitors. Now, why is that? That doesn't seem to make sense. Why would ACE inhibitors be less effective in women than men? And of course, one of the reasons probably is because ACE inhibitors are not as well tolerated in women as in men. And in fact, one of the striking differences between women and men is the occurrence of cough. It's much more common in women than men. And the reason I'm bringing that up here is that this is probably just something to do with the amount of drug per kilogram of body mass. And I think I probably don't need to tell anybody in this room that ACE inhibitors are more likely to cause cough in people of Asian origin, people who live in Asia, than in other countries. And again, it may be because of body mass. And in fact, when we went on to do the CHARM trials subsequently with candesartan, we saw no interaction with sex. Candesartan in the CHARM trials was equally effective in women as in men. And of course, candesartan doesn't have the same side effects as ACE inhibitor, and in particular, doesn't cause cough. So, of course, the next neurohumoral breakthrough was beta blockers, and these drugs really were the proof of neurohumoral mechanisms in heart failure, because back in the late 1980s, many people were describing ACE inhibitors as vasodilators, but beta blockers are clearly not vasodilators. In fact, when you first give a beta blocker to a patient with heart failure, it can cause vasoconstriction. So these drugs were proof of the neurohumoral hypothesis, and of course the evidence of benefit from beta blockers was shown on top of ACE inhibitors. And then finally, the third of the group of drugs that we would call neurohumoral antagonists shown to be of benefit were the mineralocorticoid receptor antagonists. We didn't call them mineralocorticoid receptor antagonists in those days. We used to refer to them as aldosterone antagonists. Some people even thought of these as potassium-sparing diuretics, but they're much more than that. And again, you've never seen these figures before because I've redrawn the RALS trial. Usually when you see the RALS trial presented, you see a survival figure. This is the composite of cardiovascular death or heart failure hospitalization, which is what we would use in our modern heart failure trials. And of course, you can see when the RALS trial was done, when the only background evidence-based therapy really was an ACE inhibitor, event rates in these very sick patients were extremely high, and you can see this very striking reduction in the risk of cardiovascular death or heart failure hospitalization. But this slide also gives us another very, very important message. And that message is that the benefit of a treatment doesn't depend on the background treatment that patients are receiving. You can see here that the hazard ratio here is 0.65, equating to a 35% relative risk reduction. If you fast forward to the Emphasis heart failure trial, which we published in 2011, when we were now adding an MRA not just to an ACE inhibitor, but also to a beta blocker, you can see that even though these were lower risk patients, the hazard ratio was exactly the same, was 0.63. So the treatment effect, the relative risk reduction of treatments don't depend on background treatments unless they're working through the same pathway. But these are not working through the same pathway. Now, obviously, the absolute risk reduction here is very different because these were much sicker patients. So if you have a 35% risk reduction when your event rate is almost 60% at 3 years, the absolute risk reduction is greater compared to the emphasis heart failure trial, which we did in patients with mild symptoms. And the other reason I'm sort of spending a bit of time talking about MRAs is because they're underused. I'm not sure what happens in the Philippines, but these drugs are really underused around the world. And amazingly, one of the countries that uses these drugs less than almost any other country is the United States of America, a very wealthy country with a very well-developed health service, and yet these incredibly effective treatments are only used in about 40% of patients with heart failure and reduced ejection fraction to this very day. So again, in some of the introductory remarks, we talked about implementation. Implementation is a particular problem with MRAs. And again, this table from our paper in the New England Journal describing the results of the emphasis heart failure trial really demonstrates what dramatic effects these drugs have. Very, very, very beneficial treatment. So by the late 1990s, early 2000s, we were beginning to see that we were making real progress with neurohumoral antagonists. And we were seeing this stepwise reduction in mortality and also in morbidity with the different treatments that we have. But the question was, could we do better still? And I want to move on to the next era, and the second most recent era, I would say, in heart failure therapeutics. And that was the era when we changed from thinking about just blocking the harmful, detrimental neurohumoral pathways that are activated in heart failure, but we started to think about whether or not we could enhance the endogenous protective beneficial pathways in patients. And when I was a cardiology trainee, the first research I ever did was looking at natriuretic peptides, actually looking at the mechanism of action of these peptides. And to me, the discovery of these peptides was amazing because I had always only thought of the heart as a mechanical pump. And here was evidence that the heart was an endocrine organ, that it could defend itself against pressure and volume overload by secreting these peptides. And we now know there's a whole family of these peptides. There are more than on this slide. They're not just produced by the heart, they're produced by the blood vessels and by the kidneys, and they're the body's way of protecting itself against pressure and volume overload. So the question was, could we use these therapeutically? Could we enhance them? Could we exploit them? And again, some of the early trials we did was to give these intravenously, because they're peptides like insulin, they have to be given parenterally. You can't take them orally. We give them intravenously, but you could only give them for a few days. It wasn't very effective. And we had to come up with an oral strategy to enhance natriuretic peptides. And the way we found out that you could do that was by inhibiting this enzyme. So cardiology is full of lots of interesting treatments that act on enzymes. And this enzyme, neprilysin, is an enzyme that is responsible for the breakdown of natriuretic peptides. So we realized that if you could inhibit this enzyme, you could augment natriuretic peptides. Now, it took a long time to figure out how to do this safely. And as it turned out, the only way that you can do this safely is by combining a neprilysin inhibitor with an angiotensin receptor blocker. You have to combine it with a renin-angiotensin system blocker because neprilysin also breaks down angiotensin 2. So you have to block the renin-angiotensin system at the same time. And we found, of course, that if you give a neprilysin inhibitor and an ACE inhibitor together, there's a significant risk of angioedema. So eventually, after many, many years of trying, Novartis developed this combination of sacubitril and valsartan. And of course, this is why I say 5 treatments, because sacubitril valsartan is 2 treatments. It's an angiotensin receptor blocker, and it is a neprilysin inhibitor. And we were fortunate enough, after, again, about 2 years of discussion, to persuade Novartis to fund a very large trial, in fact, what was the largest trial ever at the time, called the Paradigm Heart Failure Trial, where we compared sacubitril valsartan to what was the regulatory gold standard renin-angiotensin system blocker, which, of course, was enalapril, based on those earlier trials that I showed you. And the rest is history, as they say. This is what we saw in Paradigm Heart Failure. We saw a significant, a highly statistically significant 20% relative risk reduction in the composite outcome of cardiovascular death or heart failure hospitalization. And each of those components, cardiovascular death by itself, heart failure hospitalization by itself, was reduced by about 20%. So now we had another type of neurohumoral therapy, but it was one that was given to augment natriuretic peptides, to augment the beneficial neurohumoral pathways that operate in heart failure. So what was the next era? Well, the next, and I would say most recent era, of course, were the SGLT2 inhibitors, these drugs that are chemically similar to a compound that was discovered many, many years ago, well over 100 years ago, from the bark of apple trees, a chemical called fluorescein. It's also found in the skin of apples. It's also found in the alcoholic drink cider. If you like to drink cider, then you're getting a little bit of SGLT2 inhibitor. And of course, these drugs have been remarkable. They've really transformed the treatment, not just of heart failure, but of chronic kidney disease. And of course, were originally introduced as a treatment for type 2 diabetes. And the history of these drugs is really remarkable. So, as I said, fluorescein was first discovered back in 1835 and was shown in dogs and in humans to increase urinary glucose excretion. And it was realized back in 1835 that this might be a treatment for type 2 diabetes. But fluorescein was not well tolerated because it caused gastrointestinal side effects that were very unpleasant. And of course, the reason for that is fluorescein was a non-selective sodium glucose cotransporter inhibitor. It blocked both SGLT1, which is found in the gastrointestinal tract, and SGLT2, and that's why it caused unacceptable gastrointestinal side effects. And with the rediscovery of the gene for SGLT2 and the first development of an SGLT2 specific inhibitor, which turned out to be dapagliflozin in 2009, the rate of discovery of the benefits of these drugs was astonishing. Within 10 years of the first administration of dapagliflozin to human beings, we had published a trial in heart failure, a large morbidity mortality trial. And this is how fast things are developing these days. And of course, there were 2 trials, and we're really blessed in heart failure in that most of the treatments we have more than 1 trial demonstrating their benefits. And we did DAPA-HF, but there was also in parallel the Emperor reduced trial being conducted. And you can see here again something I think is very, very remarkable. And I'm sorry to use that word so many times, but it is truly unusual to see an almost identical treatment effect. So these are the two trials. I've used the same endpoint in these figures, and I've used the same y-axis scale, and you can see this identical hazard ratio of 0.75, equating to a 25% relative risk reduction. And of course, as we've said many times when we presented these data, the thing that really struck us was how these Kaplan-Meier curves separate almost immediately. In fact, they are statistically significantly different within just 14 days of randomization. And that became very, very important moving forward because it made us rethink about how we should use all of these treatments in patients with heart failure and reduced ejection fraction. And although I've focused on the primary composite endpoint, cardiovascular death or heart failure hospitalization, I do want to stress that these drugs do everything that you want a good drug to do in patients with heart failure. They make people feel better. They reduce the likelihood that people's symptoms will get worse. And of course, they reduce both the risk of admission to hospital, they reduce the risk of death, and they reduce the risk of progressive worsening of kidney function. And again, I can't emphasize how important that is, because anybody here who looks after patients with heart failure will know that deteriorating kidney function is often a problem, and then that becomes an issue for the continuation of treatments like sacubitril valsartan and like mineralocorticoid receptor antagonists. So preserving kidney function is a really, really important additional benefit of these drugs. And they have many other benefits that I don't have time to go into in detail. They correct anemia. They reduce the incidence of new onset anemia, another very common problem in patients with heart failure. They reduce the risk of new onset diabetes. They reduce the likelihood that patients with diabetes need to be started on insulin. Again, a very important benefit in patients with heart failure. So really, really amazing, transformational, revolutionary treatments for patients with heart failure. So this is where we've got to in terms of first-line life-saving treatment. These are our 4 pillars of treatment, but again, the reason I said quintuple rather than quadruple is because, of course, sacubitril valsartan is 2 drugs, 2 chemical entities working in very distinct and additive ways. So in total here, we're giving 5 different chemical entities. And the benefits of these treatments, I think we're still only beginning to realize, we're only beginning to come to terms with, because here you can see the extension of event-free survival over the lifetime of a 65-year-old patient, using the data from the trials to project what's happening. And you can see here that event-free survival in patients getting quadruple therapy compared to patients getting, sadly, what still many people around the world get, which is just a RAS blocker, an A or B or ACE inhibitor and beta blocker. If you use all of these treatments, you can see this remarkable 6 years median improvement in event-free survival. And I don't know about you, but because I'm getting old, I now have patients who are coming back to see me for more than 20 years. I have patients with heart failure who are coming to my clinic who first met me more than 20 years ago. When I started to do heart failure research in Scotland, the median survival for a patient with heart failure was 18 months. and now we're seeing people surviving more than 20 years. So these treatments really make an extraordinary difference. So what do the guidelines say? Well, the guidelines, of course, say use all of those treatments, but both the European and the American guidelines also changed in really important ways when the last editions were published. And there were big, big changes, not just in the treatments recommended, but in the recommendations about how we should use those treatments. And one of the most important aspects of those changes are about speed. How important it is to use these treatments quickly. All of those treatments I showed you, the pillars of therapy, are life-saving treatments. And we know that they all work quickly. We've gone back, we've looked at the old trials, we've reanalyzed the data, and for all of those treatments, you see benefits, statistically significant benefits within 2 to 4 weeks. So why would you withhold a life-saving treatment in a patient with a deadly disease? Nobody in cancer would think about, oh, well, I'll give a treatment, I'll wait a few weeks or a few months, I'll add a second treatment. If you had cancer, it would be urgent, and you would want to make the diagnosis and treat people as quickly as possible. But we've not had that same urgency in heart failure, and the new guidelines emphasize that it is urgent to diagnose and treat heart failure as quickly as possible because you have these super effective treatments. The other thing that the new guidelines, I believe, correctly say is that initiation of all of these treatments is much more important than up titration to the target dose. That's still important, but it's not the most urgent thing. The most urgent thing is to get all of these treatments started as quickly as possible. Even if it's in a low dose, that's fine. You can up titrate later. Now, why did we change? Why did we say this in the new guidelines? Again, it's because when you go back and you look at the trials, you can see that there is a significant benefit during the up titration phase. So I mentioned that in all of the trials, you can see a benefit within 2 to 4 weeks. For many of those drugs, it was a tiny dose that was being given. So, for example, in the CHARM trials with candesartan, the target dose was 32 milligrams, but we slowly up titrated from 4 or 8 milligrams over a period of 12 weeks to 32 milligrams. But in the CHARM data, when we went back and we reanalyzed it, within 2 weeks, there's a significant benefit. And the average dose of candesartan people were getting at 2 weeks was 6 milligrams, not 32 milligrams. So yes, the target doses are important. There's probably a bit more benefit from big doses, but even small doses are beneficial. And of course, the important point is that all of these treatments, because they work in different ways, their benefits are additive. So you want to get them all started as quickly as possible, and even a low dose is fine. And then the last really major change in the guidelines was that the sequence of treatments doesn't matter. And of course, historically, we'd followed the chronology of the clinical trials. The first treatment shown to be a benefit was an ACE inhibitor, so we used to start with an ACE inhibitor. Then we'd up titrate. The guidelines suggest that you up titrate the dose of an ACE inhibitor, then add a beta blocker, because that was the next type of treatment shown to be a benefit. But this makes no sense. If the treatments work independently, it doesn't matter which of these treatments you start first. And of course, you want to get them all started as quickly as possible. So the new guidelines really emphasize that these are complementary treatments. They work in different ways. They each work through a different mechanistic pathway. Their benefits are additive. They work quickly. You want to get them all started as soon as possible. And the American guidelines, I think, are particularly interesting because they also stress the idea that you can actually start these treatments simultaneously. Now, we used to be afraid of these treatments. I remember when ACE inhibitors were first introduced, we used to admit people to hospital to start an ACE inhibitor under observation, and nobody would dream of doing that today. And most people probably never dreamt of the idea that you would start all of these treatments together. Now, I still don't start them all together. What I usually do is I usually start 2 of them together and then add the other 2 more quickly. Now, maybe I'm too cautious, maybe I'm too timid. And the reason I've put this particular approach here is because we again went back and we analysed the clinical trials. We've got all of these trials in Glasgow. We reanalyzed them, and the treatments that give you the greatest benefit immediately are the SGLT2 inhibitors and MRAs. So that is, at least as far as we can tell, the 2 treatments that will give you the greatest benefit most quickly. I didn't expect that when we first put forward this concept a few years ago, myself and Milton Packer. We actually thought it would be an SGLT2 inhibitor and a beta blocker, but as it turns out, probably the most effective combination to start with is an SGLT2 inhibitor and mineralocorticoid receptor antagonist. Now, again, I want to just mention something very quickly, because just this week there was a very interesting development in this field. So, of course, patients with heart failure don't just have heart failure. Many of them have multiple other problems for which they're receiving many other drugs. And, of course, we all understand the problem of polypharmacy. Our patients complain about having to take too many pills. Their adherence may not be particularly good. So there's a lot of interest now in developing a poly pill for heart failure with reduced ejection fraction. You can see here some of the publications that have come out, but just this week it was announced that there is a large trial, morbidity mortality trial, underway comparing a poly pill to standard treatment. So it will be very interesting. This literally will be a pill where patients will receive all 4 treatments initially. So I'm going to finish soon, but I wanted just to mention that, of course, we do have second-line treatments, second-line guideline recommended treatments, and of course we have devices, but my focus is on pharmacological treatment. Now, why do we say they're second line? Well, we say they're second line because they don't reduce mortality. They do improve symptoms, they do reduce the risk of hospital admission, but they don't improve mortality. And I'm only going to talk about one of these because I think it's interesting to see how history has almost come full circle. And the one second-line treatment I want to mention briefly are the digitylase glycosides, because I said, at least in the Western world, the first description of any treatment for heart failure was the use of digoxin. Another drug, of course, obtained from a plant, just like SGLT2 inhibitors, and that was the benefits of digoxin were first described 241 years ago. In 1997, Salim Yusuf led a very famous trial called the DIG trial. 6,800 patients, a really big trial in those days, looking at digoxin. Now, the primary endpoint in the DIG trial was all-cause mortality, and the DIG trial showed no effect on all-cause mortality. But if we used the endpoint that we would use in a heart failure trial today, which is the composite of cardiovascular death or heart failure hospitalization, then there was a clear benefit driven by reduction in heart failure hospitalization. Now, the DIG trial was a curious trial in many ways. Very big doses of digoxin, which we probably wouldn't use today. And even though digoxin was superior to placebo, that was despite the fact that almost 1 in 5, or more than 1 in 5 people in the placebo group were actually started on digoxin during follow-up. So even though that was making it tougher to beat placebo, digoxin still beat placebo. But digoxin fell out of use. And in the early beta blocker trials, in the ACE inhibitor trials, more than 80% of patients with heart failure and reduced ejection fraction were receiving digoxin. In recent trials, it's less than 20% of patients with heart failure and reduced ejection fraction have been receiving digoxin. And that makes no sense because, as I showed you earlier, when I showed you the emphasis heart failure trial compared to the RALS trial, it doesn't matter what background treatment people are on unless you think the drug's operating through the same pathway. Digoxin works in a different way than spironolactone. Digoxin works in a different way than enalapril or sacubitril valsartan. So digoxin should still be effective, but people didn't believe that, and digoxin fell out of use until very recently. And in the past 2 years, or a year and a half in fact, there have been 2 new digitales glycosides presented. The first one was a German trial called DIGIT-HF, which I've shown here. This was presented at last year's ESC Congress, and now you're seeing digitoxin, it's a slightly different digitales glycoside, added on top of extremely good background drug and device treatment. And you can see here that the treatment benefit of digitales is almost identical to the effect of digoxin, as we would honestly have expected. And then just a few weeks ago, the third digitales glycoside trial was presented and published. This was a Dutch trial called Decision. This was using digoxin, not digitoxin. It was using a lower dose of digoxin than in the original DIG trial. And in JAMA, there was a meta-analysis published now putting all 3 trials together. So this is our usual composite endpoint of cardiovascular death or worsening heart failure, and you can see complete consistency of benefit. All of these point estimates line up. There was no interaction, and you can see here overall digitales glycosides reduce the composite endpoint by about 15%. And in fact, if you put digitales glycosides into our league table of treatment, so this is a league table I've created ranked according to benefit on cardiovascular death. Of course, digitales glycosides don't reduce mortality, but they do have a very large and meaningful benefit on heart failure hospitalization. You can see here that their benefit on heart failure hospitalization is as good as many of the other treatments that we use, a 25% relative risk reduction. So my good friends Carolyn Lamb and Javid Butler a few years ago produced, I thought, this very nice figure. But and the reason I liked it, of course, was that they recognized that there were 5 pathways that we're trying to treat. But I think we now have to update their figure because they had said there were 3 other treatments. They had dismissed any role for digitales glycosides, but I think these drugs are now definitely something we should be considering. So finally, I just want to look ahead to the future in heart failure with reduced ejection fraction. Now, I have to say, for the first time ever, there's less going on in this type of heart failure than in heart failure with preserved ejection fraction. Most of the new trials that are taking place in patients with heart failure and preserved ejection fraction, but there are still some treatments that we're interested in. So apart from perhaps digoxin, none of the treatments I've mentioned, SGLT2 inhibitors, sacubitril, valsartan, beta blockers, none of them act on the fundamental problem in heart failure with reduced ejection fraction, which is reduced myocardial contractility. And we've never had a safe inotrope anytime we've tried to study a drug that improves contractility. It's actually increased mortality. And a few years ago, in fact, quite a few years ago, this drug was specially developed to try and improve contractility without having the potentially harmful effect of classic inotropes like PDE3 inhibitors or sympathomimetics. This is a drug that has a very strange but very simple action, and that is to slightly prolong the duration of systole. Doesn't sound like much, but actually when we did mechanistic trials with this drug, you see an improvement in ejection fraction, you see a reduction in NT-proBNP, you see all the things that you would hope to see with an effective treatment. But when we did a very large morbidity mortality trial, we saw this very disappointing overall effect. Yes, there was a significant benefit, but it was tiny. The hazard ratio was 0.92. That's only an 8% relative risk reduction. But what we did see in one of the pre-specified subgroups was a very, very strong statistical interaction. You don't normally see interactions like this. And the interaction was as shown here. So in patients who had an ejection fraction at or below the median value, which happened to be 28%, you can see there seemed to be a benefit. But in patients who had an ejection fraction above the median value, there didn't seem to be any benefit. So, of course, with subgroups, you have to always be skeptical, but this makes sense. We saw a similar interaction with natriuretic peptides. So patients with very high natriuretic peptides seem to get more benefits that would fit with the low ejection fraction. So it's plausible that this treatment might be working in people with a very low ejection fraction. So we're doing a new trial. This is currently running to focus on patients with a very low ejection fraction to see if we can confirm that this treatment, omecamtiv mecarbil, this cardiac myosin activator, might be beneficial in people with particularly poor left ventricular systolic function. So what else is going on? Well, the main other treatments that are being studied at the moment are, again, treatments that affect aldosterone. I don't know what happened to the font here, but the two new areas that are maybe most intensively investigated at the moment are treatments with new anti-aldosterone therapies, non-steroidal mineralocorticoid receptor antagonists, and aldosterone synthase inhibitors. So as you probably know, finerenone is the main prototype non-steroidal mineralocorticoid receptor antagonist. These are drugs that have got a different physicochemical properties, different chemical structure than traditional steroidal MRAs like spironolactone. There's a lot of hype about maybe they're different, maybe they're better. We don't know that, but they do give us the opportunity to do more trials. So we're currently running a trial called Finality, where we're randomizing patients who have not been able to tolerate spironolactone or eplerenone to placebo or finerenone, so to see if this might be an alternative treatment that can be used in patients intolerant of traditional MRAs. So that's one new anti-aldosterone treatment trial underway. It's one of a number of trials with finerenone. And then the other really big area of drug development is this new family of drugs which are aldosterone synthase inhibitors. And there's a trial called Easy Heart Failure Reduced that is currently underway with one of these agents. So as the name suggests, these drugs inhibit the production, the synthesis of aldosterone. There are theoretical reasons why this might make them better than mineralocorticoid receptor antagonists, but emphasize theoretical. We don't know for sure, but again, they give us an opportunity to study new drugs. And the EASY HEF-REF trial is very like the finality trial. Again, it's a study that is comparing this new aldosterone synthase inhibitor in patients who've been intolerant of a conventional mineralocorticoid receptor antagonist. I put this slide up just to show you how all new trials now are reaching out to patients. They're sort of trying to directly recruit patients. They've got patient-facing websites in multiple different languages. And then lastly, I want to just tell you about two trials that you will see the results of at this year's ESC Congress in Munich. And these two trials are being led by our amazing colleagues in Denmark. Denmark is an astonishing country where they can do trials involving almost every patient with the disease because of their national healthcare system and their national health records. And they have been doing two trials comparing hydralazine and isosorbide dinitrate to placebo. Do you remember a trial called AHEFT, which was the African American heart failure trial, demonstrating a benefit of hydralazine and isosorbide dinitrate in Americans of African descent? So a very strange story. The New England Journal has been covering this recently, a race-based drug. And the Danes have been testing whether or not hydralazine and isosorbide dinitrate might work in non-black patients who are not of African descent. And it's a 2-by-2 factorial trial, so very clever. So patients are randomized to placebo or the combination of hydralazine and isosorbide dinitrate, and then they're re-randomized to placebo or to metformin. So you're going to see the results of these two trials at this year's ESC Congress. And if you're interested, they've published a design paper explaining everything about the trial. So to finish up, take-home message, heart failure with reduced ejection fraction, very, very simple. There are 4 life-saving tablets containing 5 life-saving drugs, and we have a duty to our patients to try and use all of these, not just use them, but use them as quickly as possible, because we want to give our patients the best chance of surviving. And as I mentioned earlier, we've also changed our thinking about how to use these. The sequence doesn't really matter. It's much more important to get them all started. And even if we start them all at a low dose, we can take our time to do the up titration later. The most important message being that these treatments all work independently of each other and that their benefits are additive and they all work very quickly. Thank you very much indeed.
Thank you very much, Professor McMurray, for that enlightening and inspiring presentation. Your insights have really provided us with a comprehensive view of the remarkable progress in heart failure management and the exciting opportunities that lie ahead in improving outcomes for our patients. Ladies and gentlemen, again, please join me in giving Professor McMurray another round of applause. Thank you. Let me just say my confession, because I was the one who crafted that topic that you provided this afternoon. And actually, I crafted 3 topics, and we actually came up with a unanimous choice that it's a quadruple therapy. And thank you for clarifying that issue. Secondly, we have a number of endocrinologists around, and with that word, that heart is an endocrine organ, so I guess that opens the idea that I would not be surprised that maybe another 5 years from now, there's an endocardiology subspecialty, no? And thirdly, just to give you some updates regarding our participants virtually, 3 countries were actually added to our list of participants from India. Thank you very much for joining us. And of course, from United Arab Emirates. And there's this Antigua and Barbados. If you're familiar with that country, it's located somewhere in the eastern part of Caribbean Sea, who happened to join us this afternoon. Again, thank you for joining us. Now, to further enrich today's discussion, we shall now hear reactions from our 2 distinguished members of the Makati Medical Center cardiology members. And for the first reactor, Dr. Ryan D. Andal is actually a respected cardiologist with specialized expertise in advanced heart failure, heart transplantation, mechanical circulatory support, and critical care. He's a graduate of University of Santo Tomas, Faculty of Medicine and Surgery. He completed his residency in internal medicine and fellowship in cardiology here at the Makati Medical Center, and subsequently completed his fellowship training in advanced heart failure and transplantation at Royal Papworth Hospital in Cambridge, United Kingdom, which is one of the most world's leading heart and lung transplant centers, and further enhanced his expertise through observership in heart transplantation at the National Taiwan University Hospital and Vanderbilt University and Medical Center in the United States. Currently a member of the heart failure team and a consultant at the Makati Medical Center. And Dr. Andal has contributed a number of research in cardiac transplantation, has been recognized for academic and scientific work both locally and abroad. Ladies and gentlemen, please join me in welcoming Dr. Ryan Andal.
Thank you, Dr. Lapitan. And thank you, Dr. McMurray, for giving us that wonderful lecture. So I'm here to discuss the practicability and reaction to this lecture. And in starting our GDMT for HFrEF, it's about choosing between adding or omitting a risk of commission or omission. And the risk for omission is that we're looking for potential harms of not trying to give new GDMT or higher dose. And for this, we will see if we omit, we will see decreased survival, increased hospitalization, decreased quality of life, and increased symptomatology. So with the 4 pillars, SGLT2 serves as a team captain. And whether these are given in combination to the other medicine, we see that balancing act of giving these 4 medication is basically on how you look and decrease the number of side effects. And so for hyperkalemia, if you start SGLT2 with the other medication like an ACE inhibitor or an ARNI, the mitigation of hyperkalemia is decreased. So it actually improves the initiation and uptitration of your ARNIs and your MRA. And so with that, it also decreases the progression of your renal dysfunction and also decreased risk of your ESRD and worsening renal function. So again, in favor of your ARNI and your MRA. And for blood pressure and risk for symptomatic hypotension, it is quite neutral if you look at the ARNI and also beta blocker. And in giving your ARNI in particular, there's a decreased risk for hyperkalemia with MRA compared to ACE inhibitors. So in giving our 4 pillars, we give our medication and we do it accordingly, and we also give diuretics. And in giving a non-selective diuretic like furosemide, for example, we tend to be in starting with hypervolemia, and then we aim to be euvolemic. However, there are risks in giving this non-selective. You tend to overgive the diuretics, and so you get to have a condition which is hypovolemia, and with that, you induce renal dysfunction. With SGLT2, your volume set point is improved to euvolemic target, and so if for a proximal diuretic like an SGLT2, hypervolemia, when you give it, you only go to euvolemic levels without upsetting the kidneys. So sacubitril valsartan is actually a sodium supramolecular complex as a crystalline salt complex. The target dose, according to paradigm trial, is 97 sacubitril and 103 valsartan. And it is given twice a day. It is equivalent actually to a valsartan 160 milligram twice a day. So it's quite a high dose. That's why it might induce hypotension in our patients. And so the correct pharmacologically prescription of this is actually sacubitril plus valsartan. And then you have to do not put the 200, but actually put the individual doses, which is 97, 103. And this is the correct way of prescribing it. So again, the target dose is 97, 103 milligram, which is twice a day. And this is evidence-based, and this is the target for most trials, and this is where we want to go. But in achieving this target dose, we do not omit the other 3 GDMT at the expense of reaching the target dose. In Asia, we tend to have lower BMIs, and so we tend to end up with just going through the optimal dose of about between 24, 26 twice a day or 49, 51. And this is more realistic. And if you see patients, that if your patients are elderly, frail, they have advanced CKD, advanced heart failure with low BP and cachectic, and they have recurrent orthostatic hypertension, then you may stop at a 49-51 and do not already attempt 97-103. So this is where our receptors or the organ distribution for the receptors for nephrolysin. And according to this, it is quite distributed. And the brain would probably have the lowest number of nephrolysin genetically by varying expression. And the 4 pillars is actually a multitude of diuretics. And it works when you give an SGLT2. SGLT2 again is a proximal diuretic. It will induce glucose to be excreted in the proximal tubule for example, about 800 millimoles. However, 90% will be reabsorbed down the line. The effect of sacubitril valsartan is actually increases your BNP. And BNP, when on high doses in the plasma, it will decrease the reabsorption of the sodium that is actually absorbed or excreted in the proximal tubule, and down the line, more sodium will be excreted. So this is a mechanistic mechanism of our LCC 696, which is sacubitril. So it will decrease or inhibit the nephrolysin and eventually increase our ANP or BNP, and it will induce natriuresis or vasodilation. And the remarkable thing about this is that it will also decrease fibrosis. And the choice to block the angiotensin 1 is actually ARB. And because ACE inhibitor will also block the the destruction of bradykinin, and so it will be additive for sacubitril. So more bradykinin is produced in the first initial phase where they tried to use an ACE inhibitor. So nephrolysin inhibition is actually the balance of the things that we need to look at. Whether we're looking at the benefits, mainly for vasodilatory and also even improvement in pain, and also the risk that it will hold, especially the presence of amyloid beta and also the bradykinin. and also the hypotension. And so here, when we transition from an ACE inhibitor, we all know that we need to decrease or stop for about 36 hours. And they are increased in the outpatient every 2 to 4 weeks. In the inpatient, the earliest you can up-titrate is 48 hours. And again, sacubitril has natriuretic effect. It has diuretic and potent vasodilatory effect. And when you have hypotension, do not panic. And also when you see increase in your creatinine, what you need to do is to hydrate first, and normally it will resolve. Before you down titrate or stop, you look for the other culprits, like the use of alpha blockers, before you decrease. And the first thing you need to stop are loop diuretics. For pre and post surgery, so Entresto is usually stopped at least 36 to 48 hours before surgery. And for post-op consideration, you have to delay restarting your ARN or ACE only after hemodynamic stability, after 24 to 48 hours post-op. And then you monitor your potassium and your creatinine post-operative, and gradual reintroduction from the lowest dose, and titrate carefully. So here are the clinical benefits and the practical considerations in the prescription of our 4-pillar GDMT. And for beta blocker, usually our target is about 55 to 60. And our timing for initiation for better toleration is that when you have hypervolemic patient, you only start it when they're already near euvolemia or actual euvolemia. And then you up-titrate every 2 weeks. For MRA, usually MRA is BP neutral, so you don't have to worry about this. The thing that we look at is hyperkalemia, and this is more pronounced if you have ACE inhibitor. And it is less seen in ARB and ARNI. And the target doses here is only 25, but we can still up-titrate to 50. And you may allow potassium as high as 5.4. And for SGLT2, again, these are BP neutral and do not use for type 1 diabetic. Start only for EGFR more than 20, and mostly the adverse effect could be volume depression, kidney impairment, and genital mycotic infection. And here's the sample, simultaneous or rapid up-titration of our GDMT, depending on the follow-up, usually every 2 weeks. So what are the potential interventions? So from inertia to actuality in our clinical practice, from knowledge awareness gaps, and also inertia, and also the applicability of our clinical trials as discussed earlier, we look at drug safety, tolerability, and also the concerns about access and cost. And for us to improve these, we need to simultaneously initiate our GDMT. We initiate this medication on inpatient process. We institute a multidisciplinary heart failure management program, and we also need to look for EMR intervention. And so in doing this, we'll be able to institute this faster and improve with our inertia. And to add on that, we need to hire and train our clinical pharmacists specifically for heart failure. We need to incorporate telemedicine and train our heart failure nurses. And nurses can actually up-titrate medication. They're not allowed to start new medication, but they are allowed to up-titrate. And they can be done in between. And also a use of point care machines in the clinics. With that, I thank you for listening.
Thank you, Dr. Anda, for that insightful presentation. So allow me now to call our second reactor. Of course, it's my great pleasure to introduce Dr. Mark Louis Del Rosario, a distinguished interventional cardiologist, educator, researcher, and of course, healthcare leader, a graduate of the University of the Philippines College of Medicine, and completed his residency in internal medicine at Rush University Medical Center. His fellowship in cardiovascular medicine at University of Missouri and advanced fellowship training in interventional cardiology at Emory University. A board-certified internal medicine, cardiovascular disease, interventional cardiology, and nuclear cardiology. He currently serves as an interventional cardiologist and training faculty here in this institution. A fellow of the American College of Cardiology, Dr. Del Rosario has received numerous awards for clinical excellence, leadership, innovation, and quality improvement. Ladies and gentlemen, let's all welcome Dr. Del Rosario.
Hello, good afternoon. Thank you, Dr. Lapitan, for that kind introduction. And of course, thank you, Dr. McMurray, for your very comprehensive lecture. I'd like to think that I was invited today to represent the everyday clinician who's seated at the table or joining us through Zoom. I'm not really an expert in heart failure, but I know that heart failure is something that we deal with on a day-to-day basis. So my take, what I got from that lecture is, number one, we've come a long way. Some of us who are already been practicing for a couple of decades might be familiar with this book. The trainees, of course, probably don't know this. This is before the age of cell phones. So this is a small pocketbook that I kept in my white coat. And it has the formula on how to compute for dobutamine drips and dopamine drips, what the dose of digoxin is. It tells you how to manage congestive heart failure. Of course, that's taboo now. We don't call it congestive heart failure. It's just heart failure. This book is probably, 25, 30 years old now. But it shows us how we've gone a long way. Listed in the book is beta blocker as a contraindication to heart failure management. And the last item in the page for heart failure says that enalapril or ACE inhibitor might be considered in patients who are post-MI with congestive heart failure. Ejection fraction was not even a term that residents knew at that time, but now even patients and medical students know about ejection fraction. So I think we've gone a long way. And what we gather from the lecture is that quintuple therapy is really the way to go. And with that, discussing the guidelines and all the convincing evidence that was laid out before us by Dr. McMurray is actually a call to action for us everyday clinicians to apply the evidence to our everyday practice. What I also want to emphasize from what he already said is that trials guide us not just on what to give, but on how to give them. He mentioned the speed or the urgency by which we clinicians should give our therapies. We should do away with a stepwise approach, but consider therapies as concomitant treatments that we should apply to our patients. I think, as the professor mentioned, that whole stepwise approach is probably a product of the historical practice of congestive heart failure. But we should look at heart failure as a neurohormonal disease that requires a multi-medical approach. And how to start or which one to start is a tailoring that we as clinicians have to learn the art and the science of. I also appreciated how he reintroduced an old friend, digoxin, how it was in and then out, and now it looks like it's going to make its way back into the guidelines. The question in my mind at the end is, have we reached the pinnacle? It sounds like based on his lecture, there are some new molecules that are promising, phosphodiesterase inhibitors particularly, and maybe some other undiscovered neurohormonal mechanisms. And then for us here in the third world particularly, treatment at what cost? And I think it's fitting that the sponsor of this forum is actually bringing a medication that would be affordable, that would hopefully make this guideline-directed medical therapy more affordable to our fellow men. And then also, new therapies that have benefit. How can we make it more affordable to our fellow men? He did not discuss device therapy, but there's biventricular pacing and all of these other therapies, very SIGWAT, which is not yet available here. How can we make it more affordable in the future? Going back to my role as speaking for the clinicians, actually the next 3 slides are actually not so much information that I'm going to share because again, I'm not a heart failure expert, but these are 3 things that I thought of as a start-off point for the open forum that is going to follow my reaction. I hope they will stimulate our audience to ask more questions. Or looking at it another way, these are the 3 things that I thought of that what would I ask Professor McMurray if I was stuck with him on an elevator for like 15 minutes. So the first one is this controversy on ejection fraction. Is ejection fraction really the best way to categorize our heart failure patients? Yes, I mean, it has been supported by decades of trials that ejection fraction is a good way, but can we make a more nuanced approach in applying the data to our patients? On a practical level, for example, if I have a patient who had an MI who has an ejection fraction of 51% with a very high pro-BNP, and I revascularized him already and he comes back still with heart failure symptoms, does that mean an ARNI won't work for him? Does that mean an MRA will not work for him? So there might be some nuance that we can apply beyond ejection fraction. And then for specific etiologies, for example, in hypertrophic cardiomyopathy, ejection fraction has been proven not to be the best way to know who will respond to therapy, but GLS is one that's being looked at by echocardiographers. And then looking at the benefit of heart failure therapy, even in patients with normal ejection fraction, it has been shown that those with bigger LV mass index actually tend to benefit more than those with normal LV mass index. So is this something that we should look at in our patients' echocardiogram that might also allow us to tailor the response to treatment? The second question I would have for him is about this controversial heart failure with improved ejection fraction. Studies have shown that once you put your patients on guideline-directed medical therapy, you should probably not, probably not stop it. And guidelines have put it, guideline writers put these in the guidelines. And that's based on some smaller but well-designed trials that show that withdrawal of therapy actually make these patients do worse. In the WITH-HF trial and in a TREAD-HF trial, they saw that if you stop guideline-directed therapy, the relapse rates might be as high as 40 to 50%. But is that applicable to all kinds of patients, right? What about post-myocarditis patients who have completely recovered from their illness? Do they belong to the same category? And then the other thing is some trials, such as the TREAD-HF and the Cathedral trials, they excluded patients with an ischemic etiology. So do these conclusions apply to patients with ischemic etiologies? And lastly, probably related also to the 2 previous questions, is about phenotyping heart failure, not just by ejection fraction, but by etiology. And then is there a role for imaging in helping us or helping guide us about what therapies to put our patients on? Is there any use for cardiac MRI and knowing whether they have scar or not to see if they would benefit more from guideline-directed medical therapy? And in a resource-limited situation, sometimes having these things that can make you have a more nuanced approach, I think, is beneficial. So with that, I'd like to thank everyone for listening. I hope you learned as much as I did, and I think this is our segue to the open forum that follows. Thank you.
Thank you. Thank you, Dr. Mark, for the timely reactions, and of course, for your insightful presentation, in the same way for posting a number of questions that perhaps we can answer during the open forum. May I request all our speakers, our distinguished speaker and the 2 reactors to please come up on stage. So we'll proceed with an open forum, and I believe this is the best opportunity for all of us. Of course, up close and personal with the author himself, Professor McMurray, to answer all your queries and questions. To our colleagues who are actually listening virtually, you can send your questions and we'll try to answer them all. Yeah, thank you. Anybody from the...
no.
Oh, yes. Can you please kindly introduce yourself and, of course, your specialty.
Yeah. Good afternoon, Professor. Good afternoon, my dear colleagues. I'm Dr. Joey Duya from the Philippines. I'm a practicing clinical cardiologist and a heavy user and a teacher of evidence-based medicine. I was discussing with my peer, we are so amazed that you are the man behind the trial. So we kept on being amazed on how the magnitude of your influence has been in the revolution of heart failure therapy. So thank you very much. It's been an honor and privilege to listen to you, Professor. So my question is regarding number 1, paradigm trial. So the paradigm trial was landmark because way back in 2017, as we were training cardiology fellows, it was when that molecule was introduced to us in the Philippines. So we were so amazed by the 20% reduction in mortality as compared to enalapril. But that observation period is short, right? It is less than 5 years, no? How come there is no data regarding the data of the paradigm trial? What happened to these patients down the line? I remember the mortality difference between the two arm, enalapril and sacubitril valsartan, was so big. No? Did it continue to have a wide separation? Did it plateau later on? And what happened to this patient? So maybe you can enlighten us. Number 2, I was so excited, because I might not have the opportunity because I'm sure there are a lot of questions. We were taught very well by our previous mentor, Dr. Abarquez, as he kept on pounding digoxin to us. But in the present heart failure guidelines, they said that digoxin works best on atrial fibrillation. Use it in heart failure with preserved ejection fraction. So I'm just curious, is there still an incremental benefit of digoxin if you are already on the guideline-directed medical therapy, at least the 5 pillars, no? Will there be an incremental benefit, or if the benefit is still palpable despite you on this therapy? Thank you.
Oh, not working.
Yeah, there you go.
Oh, okay. So thank you very much. So first of all, thank you very much for the nice compliment at the start. But you have to remember, I'm just a figurehead. I've been very lucky. I've got to lead these trials, but they depend on many people like yourself in many countries around the world. I just happen to be the lucky person who got the opportunity to lead those trials. So, thanks for the compliment, but I don't really deserve it. Secondly, you asked about sacubitril valsartan in the long term. Well, the problem with all of our trials is that they have to come to an end. And the way we run most trials is that we have a target number of people having an event that allows us to test whether or not the treatment's working in a statistically robust way. So normally, in a trial, what happens is that you run the trial until however many people have an event, stop the trial, you unblind it, you see what treatment people were allocated to randomly, and you see whether there was a difference. And for heart failure with reduced ejection fraction, because people have, unfortunately, such high event rates, then in the past the trials generally were not very long. So there's no real way to answer your question except to say that in 2 or maybe 3 countries there has been long-term follow-up of trials. So the consensus trial, which was the first trial with enalapril, was done in Norway and Sweden principally, and I think Denmark, where they have a system where every patient from the day they're born till the day they die can be tracked through the national health system in those countries. So at the end of the trial, all of those people were followed, and for example, in the consensus trial, that was until the end of their life. And so, of course, what you see actually in these trials is ultimately, of course, the two curves come together because everybody's dead. And that was true approximately after 10 years in the consensus trial. But actually, even after the end of the trial, the event curves remained separated for a long time, even though people obviously stopped the randomized treatment. That was also true for two other trials, trial in Canada and around the world called HOPE, done with ramipril, and a trial with trondolipril done in Denmark, same sort of picture. So the benefits persist. Even though the treatment was stopped, the benefits persisted for many years afterwards. I have to assume that's the same as sacubitril/valsartan, but it is very hard to get sponsors of trials to agree to do that long-term follow-up. We always want to do it. It's very hard to do. Your second question was about digoxin. So all three trials, so the original DIG trial, the DIGIT-HF trial, and the decision trial, all included patients with reduced ejection fraction, although the ejection fraction threshold was different. So, for example, in DIG it was 45%, in decision it was up to 50%, so that was unusual. And in the two recent DIG trials, a small proportion, about between a fifth and a quarter of people had atrial fibrillation. Most people were in sinus rhythm. And in the original big DIG trial, everybody was in sinus rhythm. And in the two recent trials, the benefit of digitalised glycosides were identical whether people were in sinus rhythm or not. So in fact, the evidence is that digoxin works in reduced ejection fraction, and the two recent trials, DIGIT and Decision, suggest it works in addition to all the other drugs that we've just talked about and devices. The German trial, DIGIT-HF, had a very high rate of ICD and CRT use, and despite that, despite high device use, despite modern drug therapy, there was still a benefit from digitalised glycoside.
Thank you, Professor. I have a question to Professor McMurray. With the growing body of evidence supporting early implementation of guideline-directed medical therapy, what practical strategies would you recommend for centers in low and middle-income countries to improve uptake and adherence while balancing the issue of cost and accessibility?
So I wish I had a good answer, but I don't, because I don't work in a low-income country, and I'm very privileged because in my country the government pays the full cost of all of those drugs for our patients, so we don't have to worry about cost. And actually, even though everybody says adherence is poor, we've actually done 2 studies of adherence in patients with heart failure, and it's been extremely good. It's been more than 90% for most drugs, except for diuretics, where adherence is not so good. And how I know that is that we've actually, when patients came for a clinic visit, we took a urine sample and we measured the drugs that patients were supposed to be on in their urine, and we found that almost all of those guideline-recommended treatments were being taken, except for diuretics. We found that only about 70% of people who were supposed to be taking furosemide were taking furosemide. So we're lucky. We don't have cost considerations, and we're also lucky because, like I heard you mention, in the Philippines, we are greatly assisted by specially trained nurses and specially trained pharmacists. So when I want somebody to be up titrated. I don't have to do it myself. The nurses and the pharmacists do it, and maybe in our country, nurses and specialist pharmacists can prescribe treatment so they can start treatment as well as increase the dose. So we have a lot of help. And in the UK, we have a national program. It's called the 4x4 program. So there's a national program to try and get everybody with heart failure started on the 4 treatments within 4 weeks in the outpatient clinic setting. And that is being led by specialist heart failure nurses, because every hospital, big or small, has specially trained nurses dedicated to just the management of patients with heart failure. But I mean, my colleagues here would be much better to answer the question about low-income countries. I mean, I don't know how
Actually, currently, it's still doctor-centered in terms of up-titrating and also starting the medication. By law, we still don't have the necessary bill for us to be able to give the necessary roles for our heart failure nurses to actually up-titrate medication, and more so initiate and start them altogether. We also do not have a proper training for clinical pharmacists yet. Mostly would have to come out of the country to have a 2-year clinical pharmacy training. And when they come back, and that's the time that we'll be able to start. But for a clinical heart failure nurse, for us to be able to start, and knowing that there's so many nurses abroad, and many Filipino nurses, as a heart failure nurse in the UK, there are many, in the UK they have different bands for nurses, like band 5, 6, 7, and 8. 8 is the highest. For heart failure nurse, it would be band 6. And the starting would be, of course, band 5. And so many heart failure nurses who is a Filipino and also working in the clinical sphere of the heart failure and transplantation. And so hopefully by the time we lobby this into Congress, and we'll be able to get our bill done, and we'll be able to train our patients.
Yeah.
And so our Filipino nurses would actually can come back and train the next generation.
Yeah. Thank you. Mark, can you add
Yeah,
to
actually,
that?
I just wanted to mention, I read cost effectiveness analysis on SGLT2 inhibitors in heart failure in the Philippine setting. And the conclusion of that study is that it is cost effective.
Yeah.
Obviously, we have a high burden of heart failure, and the expense both for the whole system and for the individual patient is very high. So now with cost or more affordable alternatives compared to the originator or the original molecule that's sold, probably we can get it at a cheaper price. I think it's on us as clinicians to emphasize that these medications actually work and they prevent outcomes, which are also expensive in the end.
So I would like to stress that the UK's a third world country as well. We're not rich. We do spend a lot of money in healthcare, but we're not a rich country. And all drugs that are approved in the UK have to be shown to be cost effective. That is the basis for government approval of any treatment in the UK. So all of these treatments have all been shown to be cost effective, even the original compounds, for the reasons that you say.
Thank you for that. Dr. Cibula, you have a question?
Tough question.
I just would like to comment on when you mentioned that Filipinos cannot tolerate the dose. And I agree with you. The protocol was presented to us in the Philippines. I complained about the 200 milligrams 2 times a day because it's 160 milligrams of valsartan twice a day. And I said, no way can the Filipinos tolerate this small BMI. So you remember Dr.
I remember. I remember.
Just try it, and maybe later we can adjust the protocol. Let me share with you the tolerance of sacubitril valsartan in the Philippines. Towards the end of the trial, the global capability to tolerate 202 times a day global was about 87 or 88%. The Philippines was 92%. So we had the highest tolerance to the drug for sacubitril valsartan. So it's not true. We just have to persevere to increase the dose from 50, 100 to 200 milligrams. Of course, when you talk about the paradigm HF, some would say it's biased because you're just choosing patients who could tolerate. That's true. The run-in was 100 milligrams BID after 2 to 3 weeks, 200 2 times a day. If you don't tolerate, you drop off. So there was something like 13,000 patients who went into the run-in, and only 8,000 went through. But that is acceptable because the paradigm HF is a superiority trial comparing your ARNI versus enalapril. Okay, anyway, I have a question. My question is, are there any researches on this disease biology pathway that looks into myocardial fibrosis? Because to my mind, some patients who are maintained on GDMT doses, but the ejection fraction no longer improves. And maybe there's myocardial fibrosis present. And maybe look into also the immune activation, wherein there's so much pro-inflammatory cytokines like your TNF-alpha, interleukin 1 and 6, to explain why there is failure to improve the ejection fraction. Of course, the EF was not an endpoint for the paradigm. And the endpoint, we only saw that with the PROVE-HF trial. The PROVE-HF show drops in BNP, improvement in left LV indices and LA diameters. So I don't know if we are targeting those indices.
Okay, well, thank you very much. So you're absolutely correct. I remember very well the conversation we had about tolerability, and we had the same conversation with our friends in Japan as well, because they said Japanese patients cannot tolerate these doses, and they also had a higher than average adherence in the trial than many other countries, including America. In terms of fibrosis, a very good question, and obviously we have evidence with several drugs, so sacubitril valsartan is one, but MRAs are another, where we see at least circulating biomarkers indicating increased fibrosis or turnover of extracellular matrix are reduced by those treatments. I don't know of any imaging studies, but I do know we see biomarker indications of reduced fibrosis with sacubitril valsartan and with MRAs. I don't know of that for beta blockers. We've looked and did not find it with SGLT2 inhibitors, which is interesting. And another trial to look out for at ESC this summer is a trial done selecting patients for ICD implantation based on fibrosis identified using cardiac MRI. So the idea that we're not very good at identifying patients who benefit from ICD treatment, maybe we could be better if we targeted ICDs to patients who have a certain amount of fibrosis on cardiac MRI imaging. So that ICD trial is being presented at ESC. And was there another bit to your question? I can't remember. My brain's... That's it. Okay.
So
Yeah.
actually, the MRAs do have anti-fibrosis. It's probably one of the more potent anti-fibrosis medicine out of the four. So I saw one journal that actually showed that without an MRA, there are macrophages in the organ. And then when you start the MRA, the macrophages are actually decreased. So the mechanism for the anti-fibrosis depends really on, because it's aldosterone is a hormone, so it's a steroid. And blocking that pathway will also decrease. And I showed earlier, I had a slide that sacubitril valsartan do have anti-fibrosis. Aside from that, and there's new novel drugs would be the anti-inflammatory medication drugs.
That was the other
and
question.
anti-fibrosis. And one would be pirfenidone. Pirfenidone is a medication that we use for ILD, interstitial lung disease, for lung fibrosis. And that drug is now still under trial. It showed that it decreases the extracellular volume or by 0.7, and the significant one will be 1. And so it's something that we're looking at in the future. And of course, the biologics, the interleukin-1 inhibitors, as you said, are also being looked at.
Thank you.
Yeah,
Thank you for that.
That was the bit I forgot. So you're right, of course, the IL-6 inhibitors are of interest in heart failure, and my friend in Glasgow, my colleague Mark Petrie, is running a big trial in patients with heart failure and preserved ejection fraction using an IL-6 inhibitor. And that trial, which is called Hermes, should report in 2 years' time. We would like to do, and we've been trying to get a sponsor interested in doing a similar trial in HFrEF, because in DAPI-HF, we found that IL-6 levels are elevated in patients with HFrEF as much as in HFpEF, and they're a very powerful predictor of prognosis. Doesn't mean that reducing IL-6 activity will be beneficial, but it certainly suggests it could be, and we'd like to do that trial. So you're absolutely right, as usual.
Thank you. In the interest of time, I'll just read one of the key questions from our
You have to answer this.
from our cardiologists who are actually listening through online. One is, on a practical perspective for HFrEF patients whose EF has recovered and stabilized for 1 to 2 years, is there a room to scale back or de-escalate the dosages of the 5 therapies? And if so, how do you suggest these patients are monitored?
Okay, well, let me share with you what I read about this topic, particularly about de-escalation. So one small trial, I think it was a Korean trial, the WITH-HF trial, that included ischemic and non-ischemic heart failure, few hundred patients. They saw that, so this was a de-escalation with MRA, so this is specifically spironolactone. So they saw that if you remove spironolactone from the treatment, there's more than 40% relapse. So that might be related to the fibrosis issue with how it prevents fibrosis, both in the post-MI and maybe in other etiologies of heart failure. So I guess the answer to that question is based on the limited trials that we have right now, it is probably not prudent to de-escalate unless there's a reason to do so. And the other thing about, going back to the fibrosis question earlier, I remember your slide about starting the MRA early, and that might be also a reason why you have to start it early is because of its anti-fibrotic effect. Sorry, I just had to say that.
Okay.
Good. So I agree about the discontinuation. I mean, it is very tricky, and it's where the art of medicine becomes important as well as the science of medicine, because large trials don't cover every single patient possibility that we encounter in our everyday practice. But just to say, interestingly, the decision trial, that most recent digoxin trial, they also did a withdrawal study, and the event rate increased dramatically on withdrawal of digoxin. And of course, there are 2 old trials, very old trials, one called Proved and one called Radiance, which also showed very early deterioration after withdrawal of digoxin. And then remarkably, many years ago, and everybody's sort of forgotten about this, there was a German study with quinapril that was a randomized withdrawal of quinapril, an ACE inhibitor, in patients with heart failure and reduced ejection fraction, and they deteriorated. So on average, the evidence is that people will deteriorate. But I think you're absolutely right. There are occasional patients, the patient with myocarditis, the patient particularly with peripartum cardiomyopathy, those young women hate remaining on lots of drugs, and some other patients with tachycardiomyopathies, where you might consider withdrawing treatment. I normally try and keep people on a beta blocker if at all possible. I don't know why, but I feel that that might be the most protective. So if a patient insists on stopping treatment, then I might, for example, stop the MRA, but I want to keep the beta blocker. But you have to watch them very, very carefully. You have to monitor their natriuretic peptides, I would say today, their cardiac function, because if those start to deteriorate, then you need to get them back on treatment. And the problem I always say when I get asked this question from my own experience is sometimes if people deteriorate, then when you restart treatment, you don't get their ventricular function back to the level it had been. So that's the risk. If you stop treatment and you deteriorate, you might not get the same level of recovery that you had. So it's a difficult conversation.
Okay, thank you. So unfortunately, our time is limited. I'm afraid we have to close this session. And in behalf of all the participants, also the virtual participants, we would like to thank Professor John McMurray for sharing your expertise. Also to our two reactors, Dr. Mark Del Rosario and Dr. Ryan Andal. My apology, Dr. Alan, you can approach Professor later, at least up and close personnel. So with that, again, thank you very much. So may I please stay up here on stage? May I call on Dr. Javier, Dr. Rosas, Dr. Joel De La Rosa. Is Dr. Camponia still around? No more. Nandyan? Come on stage to award the plaque of appreciation to our distinguished guests and reactors. Also, Mr. Manoj and the country manager of Camber and Maki.
Oh, yeah.
Yeah.
Oh, I can't.
The plaque reads that the Makati Medical
Thank you very
Center
much.
Heart Institute, together with the Department of Medicine and Section of Cardiology, present this plaque of recognition to Professor John McMurray as MHI Distinguished Speaker for the first Heart Forum on the topic, The New Era of Heart Failure Therapy, from Neurohormonal Blockade to Quintuple Therapy. Given this 13th of June, 2026, 8th floor, Auditorium Tower 2, Makati Medical Center, Makati City, Philippines, signed by Dr. Rosas, Director of Professional Services, Dr. Saturnino Javier, our Medical Director, and Interim Co-President and CEO of Makati Medical Center, and yours truly as Director of Makati Med Heart Institute. Thank you. Same plaque of appreciation to our two distinguished reactors, Dr. Mark Del Rosario and Dr. Ryan Andal. At this point, we'd like to acknowledge our valuable support from our industry partner who truly made this